because honestly, we don't have the resources or capacity to do so. If someone wishes to write a letter and send it out, we are happy to do that on their behalf. We don't endorse anybody or recommend anybody. This is literally people that are looking to add to their faculty. We would be happy to send that for them to the fellows. So fellows, you may receive something like that from us. And so that's the genesis of the letter. And there will likely be more than one that periodically comes along. So just an FYI. So that's it.
There's been a little, Kathy, there's been a little, this is Bob Lisek, there's been a little stuff back and forth using the fellowship thing that was put together with all from all the programs. So that's helping. And it also turns out that some survey, one of our residents who's interested in MS showed that interest in MS of the subspecialties has gone up the highest percentage in the last 2 years. So we're finally getting the message through.
That's awesome. And I can tell you, I certainly agree with that, with the number of applicants that we have for our clinical fellowship. Between our institutionals, which is the 5-year grant, and the 1-year grant, it is rising significantly every year. So that is fabulous news. We just now need the resources to fund them all, right?
Yeah. One small other issue, Kathy, if I could have you take the initiative on explaining or making just a very brief comment, and that is related to our discussion about, at some point in the near future, having a scientific clinical symposia of the fellows. Maybe it's not completely cooked, obviously, but we discussed this, and I think it's a very exciting dividend of the program. So you want to just say a word, just a minute?
Yeah. Yeah, so I think Elliot and I have certainly spoken of this, and there's just such an enormous amount of expertise in the faculty and including the fellows as well, and that we think that there's a wonderful opportunity to share that amongst the group. And we currently have had a program for advanced MS that we're kind of rethinking. What might that look like? What should it look like? And so I think this could potentially be an opportunity where we share some of this growing expertise and these very interesting cases, and I think other things that the fellows are involved in. It's an opportunity for face-to-face networking as well as just a sharing of important information that I think will enrich everyone's practice and we always hope improve the lives of people living with MS. So kind of in its infancy stages and thinking stages, but certainly something that we are entertaining. And I
love the fact that you underscore a really important principle, and that's the issue of interactions, and particularly at a time when many of the major universities, medical schools have taken, I think, overly very stringent conflict of interest guidelines. So even though you might attend meetings that are orchestrated by all of the pharmacy companies, so the issue about bias is baked in the cake. The problem with that is almost everybody I've ever met that I recruited or developed collaborative investigations with, we principally met at meetings. So I think the ability to get these 18 fellows, and then of course the Sylvia Lowrys and the others together, and hopefully with a number of the faculty for the program, I think this is a really, really important thing to do. If you're building programs and you really want to be identified as a player, be invited into trials, it's not enough to be great behind closed doors. You have to be seen, you have to be heard, and it would be helpful to also be read. But I think reading is great, but face-to-face, in-the-flesh contact with colleagues, I think, is sorely lacking since these guidelines have been into place. Now, obviously, there's not an industry component here, but money is either the limited factor or it drives it. So I'm hoping at some point in the future, Tree and I will be successful in identifying potentially a philanthropic donor to try to endow a program that income generation from that, God willing, will be more than sufficient to have at least this program on a yearly basis. So end of story, except one thing. Kathy, did I hear you say there's a big shortage of neurologists, or we have many short neurologists?
Well, I believe I was referring to the former, not the latter, but it could be true as well.
Okay, we'll start. Yeah, the fact that people are laughing tells me something important before we get going. And I see my comrade and my liege, Ethan Meltzer, on, is that those laughs tell me a couple things that are important. There are people participating tonight who have a pulse, they're breathing, they're awake, and I hope paying attention. If the laughter is any reflection, they are. So the first presentation is going to be from our colleagues at NYU, New York University, Langone School of Medicine and the Comprehensive MS Center. And we have Dr. Wallach. Is it Asya?
It is Asya. You got it right.
Fabulous. Now, where are I'm going to take myself off the video because it's already a big dose of Frohman, but are you on the video to present or do you not have a camera?
I have a camera, but I sort of hid it. Would you like to see my face?
No, let's get started. If you're a little nervous, maybe Galetta will come by or Laura. Laura Balser.
I saw Laura Balser's name pop up, so maybe they're staring at it together somewhere.
We're here, Elliot. We're back.
There they are. There they are. And just for Laura, I brought
to hear your voice there.
Yeah, as I brought up the short neurologist thing, Laura, just let's remember, in the animal kingdom, it's brain to body weight ratio. Except somebody told me that stops at dolphins, so I'll just leave it at that. So, Asya, tell us what you have.
Sure. So, so you know the crew here at NYU, obviously Dr. Balser, Dr. Galetta. I work closely also with Dr. Lauren Krupp and Dr. Ilya Kister, and today I'm going to be presenting a case that proved to be a dilemma to our center. So let's see, how do I advance? First question. Okay, so this is a young woman. She was diagnosed with pediatric onset multiple sclerosis at the age of 17 back in 2012. At that time, she had a mild upper respiratory tract infection and subsequently a few weeks later developed vertical diplopia and poor balance. An MRI was performed that was abnormal, significant for a high lesion burden, including 5 enhancing lesions. 2 months later, she had another clinical event with blurred vision on the left, a dense homonymous hemianopsia, and a large parietal lesion. She had an OCT performed that demonstrated thinning of her left nerve, and her EDSS at that time was estimated to be a 1. Her history otherwise was felt to be essentially not significant. She just had a mild head injury at the age of 8 without any associated loss of consciousness. She had a normal birth and developmental history. She has one grandparent with multiple sclerosis and a distant relative with rheumatoid arthritis. She's living in New York. I have some baseline MRIs for you to look at just to get sort of acquainted with her history. So you can see she did have a large parietal lesion, a few small corpus callosal lesions, and a small lesion in the left middle cerebral peduncle.
Could you go back one? I'm sorry. Could you go back one slide? I just want to ask a question about this history. So you described number 2, this blurred vision left eye, or blurred on the left, and she had this dense homonymous hemianopsia. Let's be clear. This dense hemianopsia was present in both eyes, right, to the left. Mm-hmm.
Right.
Saying. So are we thinking, just for our edification, teaching? There are other folks on the line. I'll say, without looking at the scans, where likely is that lesion that produces this dense left homonymous hemianopsia?
Well, you're thinking somewhere along the right parietal occipital.
Okay, and the part of the visual pathway, the afferent visual pathway that potentially could be involved. It may be different places, but probably easier in some places versus others. Like if it's radiations, you might have to have this, being an enormous lesion, but if this was, any other ideas? Again, not that it's in the zone where visual pathway projections are occurring, you're quite right, but in terms of this, there's a little bit of an additional factor that one can think about depending on where it is, and that is, if this was a right tract lesion, then the question I would ask you at the bedside, remember if it's optic neuritis, you may have an APD on that side. But in a case like this where you hit the tract, and if it's before, again, for peeling off the pupillary fibers that exit, don't go to the LGN, but go to the brachium of the superior colliculus, and then midbrain parasympathetic. So I think, do you know what I'm about to ask? And that is, if you were to have a relative afferent pupillary defect in this patient, which side would it be on and why? No checks. Let's say we've got it in the right tract, and you've got a fairly dense homonymous hemianopsia.
Mhm.
And I'm not trying in any way to uncouple, because I see other folks on that I can actually call on. It's going to be beautiful. But that's not the point. The point is the teaching pearl. And your comrades at NYU, including Laura and Steve, published a beautiful paper maybe last year about this. That's the idea that the pupillary constrictor fibers are just a smidge. Correct me if I'm wrong, Laura, if that's changed, or Steve. The pupillary constrictor fibers are a bit more crossed than uncrossed, so 53 versus 47%. And it's thought that that may be more than sufficient to produce an afferent pupillary defect on the side opposite of the, in this case, let's say a tract lesion. So right tract, left relative afferent pupillary defect. Laura, any other comment about this? I know you guys had a beautiful case report that was published on this maybe last year or the year before. And our residents years ago, we published a paper with a fairly large arachnoid cyst in the posterior fossa that was compressing the brachium of the superior colliculus, which is where the pupillary constrictor fibers will enter the midbrain. And that patient had a contralateral relative afferent pupillary defect. By the way,
with the greater field loss.
Correct. That's the correct answer. Most of the times, it's in this case of a left homonymous hemianopsia, you're going to lose 30 degrees more field in the left eye than the right eye. So the temporal field is larger than the nasal field. So yes, it's usually going to be in the eye with the temporal field loss. But real rule is on the side of the greater field loss, as Laura stated, because occasionally when you have an incongruous homonymous field defect from an optic tract lesion, one of its hallmarks is that the nasal field can lose greater field and therefore more pupillary power than the temporal field. That's a rare exception.
Yeah, and your paper was beautiful because you guys, you and Laura, I think, had really beautiful anatomic correlation with what we saw in terms of geographic distribution of the pallor in the neuroretinal rim. That was one of the more important and interesting aspects of the exam. And if you're paying attention, it fits together. So there's maybe we can get that reference from you guys to have everybody on tonight take a look. It's a really short and sweet, but I think it does drive home an important set of principles about the anatomic localization. Okay, Asya, I apologize.
That's okay. I'm
going.
sorry. I'm sorry. Unfortunately, I don't think that the ophthalmologist who initially saw her appreciated an APD, but who knows if it was truly there and missed or not there. So just to give you a little bit more history about the way that her disease was managed, she was started on natalizumab, had it for just a few months, but because of a busy travel schedule, which made compliance difficult, she was quickly switched over to glatiramer acetate, which she continued for nearly 1 year, but developed new lesions and had to go back on natalizumab. Now she was on it for almost 2 years, but again, because of study abroad issues, she had to be switched to something that she could take more reliably. So she was placed on fingolimod, which she continued from August 2016 up until the fall of 2017. She was clinically stable on this treatment, but she developed some new radiographic disease, which you can see on this slide. I have a couple of arrows demonstrating it to you. Fairly small lesions. You can see one in the right frontal lobe and several in the spine. So this relapse led to a decision to switch her from fingolimod to ocrelizumab. She continued on the fingolimod up until the day prior to starting ocrelizumab. She received 2 half doses for a full cycle without any issues and continued to have a normal examination, was totally asymptomatic, essentially up until she was due to receive another dose of ocrelizumab. But before that could happen, 6 months from her last fingolimod and from her ocrelizumab, after being clinically stable for 6 years, she developed new neurological symptoms over the course of 4 hours, which I have detailed here. So her symptoms included a left hemiparesis, worse in the arm than the leg. She had effortful, slow speech, a left facial droop, incomplete eye closure, and a feeling of blurriness in the eye. but ophthalmology did not feel like this was consistent with any optic nerve involvement. Her exam was significant for the left hemiparesis. She was anti-gravity or less in the upper extremities and about 4 out of 5 strength in the lower extremity with preserved sensation and cerebellar function. She had a markedly slowed gait, which was timed at 7.9 seconds with decreased left arm swing and circumduction of the left leg. Her EDSS was estimated to be a 4 at the time of relapse. And here is a representative MRI from this relapse.
Somebody has their, I think maybe go to mute. Maybe everybody could mute until you ask something so we don't have to.
It's Bob Lissack. If you go back to that slide, and I know Steve Galletta has heard this from me for at least
Which
3
slide?
years.
Oh, the previous one.
Rombergs are not negative. They're either present or absent.
Yes.
And the second thing is it's not a cerebellar sign at all. It's a sensory sign. That was the point of his paper.
Noted. Sorry about that.
Oh, don't be sorry.
No, don't be sorry about that, because the scale that's used, the modified EDSS that the Europeans have promulgated, that's used in a lot of trials, have it in the wrong place as well. So don't worry about it. There's some very famous people who haven't gotten that straight yet.
Yeah, and don't feel badly. I don't know if you've been on these before, but that's Uncle Bob. And let me tell you something. That's a pearl. I would just say, I love it. Thank you. And I won't spend any time tonight telling you about all of the misstatements and errors that I've made. But Uncle Bobby is here to protect us. So thanks, Bob.
No worries. Thank you. Okay.
Wonderful.
So on to the MRI. I'm clearly drawing your attention to one very specific lesion on this slide. And this is about 2.5 by 2 centimeters. It's a large tumefactive lesion. It's dark on T1, heterogeneously hyperintense on T2 and FLAIR, with some heterogeneous contrast enhancement that you can see on both the axial and the coronal sections, a little bit more at the edges perhaps. I also have a DWI and an HD for the same lesion. And you can see a little bit of restricted diffusion, but nothing overwhelming.
Hey, Asya, can you go back one? Before that one, you had mentioned that one more. Yeah, right there. The designation of tumefactive, which raises the suspicion of, look, you don't want to miss things that will kill people, harm them. And there are points of differentiation, even if they go on to biopsy. But look at your bottom left axial image for that lesion. I think the one thing that would be interesting to point out is if that was a high-grade glioma, for example, that lesion you have there is so comfortable, so clean. It's not pushing any guys out of the way. And you don't see that vasogenic edema that you might see associated, not with all, but with a greater proportion. And by the way, it can go the other way. There are tumefactive lesions that can produce quite a bit of vasogenic edema and mass effect. But when you look at this, one would probably say, it could be, but not a high-grade glioma. This is not always, but likely something different. And the tumefactive inflammatory demyelinating lesion is a good idea. Okay,
yeah,
that's my
certainly not a high-grade glioma. I think one could see a little bit of mass effect if you just kind of look at the center of the brain, and maybe the right hemisphere is pushing the left just a touch. But I agree with you. Certainly not a high-grade glioma. Just to show you some of the other lesions, this wasn't the only one. She actually had a total of 8 new T2 lesions. And the other lesions look, much smaller, something that we are much more comfortable calling in line with her regular MS. And I pointed those out with arrows as well. So from the radiographic perspective, just as you had suggested, it screams multiple sclerosis relapse, but other things to potentially keep in mind that are much less likely include lymphoma and very, very unlikely glioma, given the absence of any evidence of any hint of a lesion on her prior imaging scans. And also PML, very unlikely. This is not something indolent, and she has always tested negative for JC virus. So we felt pretty comfortable ruling out PML as well. Her labs were significant for CD19 cells starting to come back at about 3%. But routine labs were negative. She had a normal UA, and some rheumatologic labs were done at this time as well, and those all came back as negative as well. So she was hospitalized for this.
Quick question, if I might. Do you know how low her B cells got after the first cycle of ocrelizumab? We often check it.
Great question.
Mm-hmm.
Yeah, it is a great question. So we typically check, right before they're due for their next infusion. And this was the first check in our system. There's a suggestion that they were checked at an outside hospital and they were less than 1% at that time, but I wasn't able to find an actual original document that stated that.
We like to do both.
So I'm not sure if it ever happened.
Both if we can.
I'm sorry, Bob, could you repeat that? I had a hard time hearing it.
I said we usually like to do both. Get it a month or two after if it's not too inconvenient for the patient, and then before the next infusion. We do the same with rituximab for, let's say, myasthenia and so on and so forth. So it's just sort of to see what goes on, because in this case, since the patient was on fingolimod, their baseline before that infusion might have been a mild but definite suppression of their circulating B cells, because B cells and T cells and in animals, monocytes are trapped in the lymph nodes. So everything goes down except the relative and occasionally the absolute number of CD56 NK cells. So one of the arguments when you switch to ocrelizumab or anything else from fingolimod is the drug you're giving. Remember, this is a monoclonal antibody, going to get into the lymph nodes enough to suppress them. Now, you would think so, since rituximab gets into lymph nodes when you treat lymphomas, but you don't know, and no one's really looked at that I know of.
I agree.
By the way, that's a great point. And Bob, we usually will do baseline and then monthly subsets with Rituxan at least. I would think, somebody's got. Could they turn off their microphone? A lot of static there. Yeah, so the one thing is we know patients develop binding antibodies to monoclonal antibodies. And the nice thing is you're not looking at a cytopathic effect assay like interferon. Here, if you check a month later and those B cells are not going to zero, they're staying up, it might be that you might be one of the rare patients that has binding and neutralizing antibodies. So we'll do subsets throughout. And then primarily because if we did Rituxan and NMO, and we gave a patient a gram, and for 3 cycles, they always came back within 10 to 12 months. And then you get a little cocky because you profiled them and say, I'll just give it a gram and I'll check it. Basically look at the labs at 9 months because they were always 10 to 12. The problem is if they have a precocious return for whatever is going to happen, now you've got an NMO patient with a catastrophic relapse. It does happen. It happened on my watch. So the idea that you'll determine when that individual patient will come back, it might be true for a while, but it may not be true forever. So I think that's a point of caution with respect to surveillance of the return of the B cells. Okay, sorry.
Just for that first interval, you'll check them on sort of a monthly or bi-monthly basis, and then
monthly. That's what we do.
Okay.
Yeah.
We don't do it quite that often, but the other point to make is that rituximab is not as humanized as ocrelizumab, and therefore blocking antibodies are probably, and I don't know if anybody's ever studied it, a little more likely to occur. And that's when the lymphoma leukemia patients, when their B-cell lymphomas come back, the first thing the oncologist will do is see if there's a blocking antibody to rituximab, which again is not as totally humanized and it's theoretically more likely to occur than with ocrelizumab. But
by the way, the Rituxan, Bob's quite right, is a chimeric with a human FC framework and a mouse hypervariable FAB2 was part of the rationale for Genentech to make the humanized Ocrevus. There's also a bigger story about money, between Biogen and Genentech, but that was the idea. Important to point out, it's a chimeric antibody. Okay.
Alrighty. So all in all, she got 8 grams of methylprednisolone over the course of about 2 weeks, and she felt like she was about 90% better, including her left face, her arm, and her leg were much improved. She, of course, attributed this to pushing herself to stay active, but regardless, she was doing a lot better. So we actually got lucky, and we didn't need to treat her with anything in addition to the steroids. You can see her exam here. Basically everything improved, including her speech and her strength as well. And her sensation and her coordination were normal. However, even though there was a good improvement in her clinical status. Her MRI really did not improve. I sort of have these images set up right to left. I hope that doesn't scare anybody, but basically,
I think that's the Hebrew variant. That's the
it
way
is the Hebrew variant. You can see that the lesion is certainly not getting better, and maybe it's getting a little bit worse, and maybe it's appearing a little bit more tumefactive over time with that extra edema around it. That's what it looks like. We saw her 4 months later in November. By this point, we had started her on natalizumab again, and she felt well. She felt like she was 100% back to normal. Her motor exam showed just very minimal deficits in her left tricep, hip flexor, toe, and finger taps, but was otherwise normal. Ooh, I skipped ahead.
Black hole.
So finally, by this point, you can see that her imaging is starting to improve. That lesion is getting a little bit smaller, but she did develop a new lesion, and I pointed out with an arrow at the right cerebellar peduncle.
By the way, go back just one more time. The top right, that top right, if you follow it from the center out, even though the center has this sort of peculiar morphology, nothing predictive about it. Sometimes this is not that, but popcorn lesions, venous angiomas. But the point I was getting to, if you look at that lesion carefully, you could imagine if you had a couple of concentric rings, that center, there's almost a ring-like structure. And sometimes these can evolve into sort of the so-called Baylos concentric sclerosis. It's not classic for it, but it just had me think about demyelination, remyelination, kind of having like an onion bulb in your head that you might have in CIDP peripherally. Okay, that's fine.
And so in the little remaining time that we have left, I wanted to discuss why this large uncharacteristic relapse occurred. What could have been the best way to prevent it, and what should the treatment approach be going forward? For the first question, I was wondering if maybe this could have been a reflection of having high pre-treatment disease activity. We know that younger women are more likely to relapse. Is it fair to call this a rebound? In other words, increased disease activity following fingolimod discontinuation? Is this some lack of benefit from her anti-CD20 therapy, or some combination of the above factors?
By the way, one other thing, and you said it very nicely, but let me just plug this in, and that is discontinuation of intensive immunotherapy. And this idea of, is it rebound or recrudescence of the primary disease process? But let's not forget there's another acronym which can sometimes look and smell, and in fact, maybe the same mechanistic sequence, and that's the inflammatory reconstitution immune syndrome, or IRIS. And what's really happening during IRIS is this sort of unchecked before suppression, remove the therapy, the drug, and these cells are quite irrationally exuberant. And the pattern to me in some of these cases is completely indistinguishable from IRIS. And if you think about it conceptually, in a way, this is sort of what you tend to see. Okay.
Yep. So I just wanted to walk you through the sort of busy slide. So on November 20th, 2018, as I'm sure everybody knows in this audience, the FDA came out with a warning about a severe worsening of multiple sclerosis. What's that?
We have some interference. Please, if you are not presenting, make sure that you mute your lines, please.
Yeah, I think somebody's at a pool party. Could we get you guys to mute until you're ready to ask? Thank you.
So at the end of November, after this event with our patient, the FDA came out with a warning about a severe exacerbation of multiple sclerosis in the setting of stopping fingolimod. And this is truly in line with a number of research studies that have been published in the last few years. So this one over here, Hatcher et al., that published in JAMA, reviewed 46 patients who discontinued fingolimod for any reason and found that 11% of them, or 5 cases, had a clinically severe event consistent with a rebound within 4 to 16 weeks of discontinuation. Frau et al., down here in the left, reviewed 100 cases that discontinued fingolimod, and they found that 26% of those patients had some kind of relapse within the course of 6 months, narrowing down to the more severe kind. So patients had a severe relapse defined as an EDSS drop of at least 2 points or more than one relapse in 6 months. And the super severe kind, an unexpected severe relapse that was so bad that the patient never had a similar relapse of equal or greater magnitude to it during the course of their illness, represented 5% of their cohort, and all of these severe cases were young women. Finally, Sato and colleagues examined the clinical and radiographic characteristics of patients who discontinued fingolimod in favor of Tecfidera for at least 6 months. And they found that 3 out of 19 patients, or 16%, developed a tumefactive demyelinating lesion. Now, this is in contrast.
A lot of feedback. Anybody that has their phone, could you turn it and mute it? We're getting a lot of feedback.
This is in contrast to the post-continuation disease activity that was found looking at the fingolimod and placebo arms of the FREEDOMS and FREEDOMS-2 trials, which did not find any difference between the, I'm so sorry, no, that was bad.
What happened?
Oh, I had a firewall thing pop up, and I thought you guys were going to have to watch that.
No.
Okay. So that trial did not find any difference between fingolimod and placebo. So then let's look at some evidence from neuropathology, and I think we sort of started talking about this already. Several patients have actually died in the context of a very severe multiple sclerosis exacerbation following fingolimod discontinuation. This particular woman had pediatric onset multiple sclerosis, was treated with natalizumab for 11 years, switched to fingolimod because she was JC virus positive, and was on it for about 3 years, doing very well until she decided to pursue pregnancy, and then had an extremely severe relapse 4 months later where her EDSS score dropped to 9.
Iris. Yep, Iris. Keep going.
Didn't respond to steroids or cyclophosphamide, and ultimately passed away due to septic shock. And she had an autopsy performed, which was very informative. It showed several active demyelinating lesions, large reactive GFAP-positive astrocytes, often with multiple nuclei and inclusions in the lesions in periplaque white matter and adjacent gray matter, as well as normal appearing white matter far from the active areas. There was strong sphingosine 1-phosphate receptor 1 immunoreactivity observed on the hypertrophic astrocytes in the active lesions and even in the periplaque normal areas. And S1P stimulation is thought to lead to astrocyte proliferation, astrogliosis, nitric oxide production, and NF-kappa B translocation in the astrocytes. And so the thinking is that fingolimod withdrawal may be leading to a massive release of inflammatory cytokines, like you said, Iris. There's also the experimental autoimmune encephalomyelitis model of MS, which has demonstrated fingolimod withdrawal can lead to an overexpression of the S1P1 receptors on the lymphocytes that were previously trapped in lymph nodes, leading to a clinical rebound. Then I also came across something called the field hypothesis, which suggests that maybe there's something specific to the CNS tissue that triggers a focal inflammation. And after the cessation of this sequestering therapy, autoreactive T cells can traffic into the brain and cause unexpected disease activity. There's also work from immunophenotyping literature that teaches us that fingolimod-induced lymphopenia doesn't affect all the lymphocytes equally. There's a greater reduction in CD4 cells than CD8 cells, and a decrease in the CCR7 positive cells, which are the naive T cells and effector memory T cells.
Asya, can I stop right there for 1 second?
Yeah.
And that the point that you just made is really elegant and important. So without getting into the machinery of CCR7, the question I would like, maybe if you could address, is this dichotomization between effector versus central repertoire cells, and why is that important in terms of preferential sequestration as well as population of tissues throughout the body, but while maintaining response to recall antigens, which is what we're talking about with effector cells. So any comment about central versus effector?
I'm not sure, no.
Okay, well, principally, and what I'll do is, who's chiming in? I'd love to hear what you have to say too.
I'm not trying to chime in. It's Scott here. Listen, number one, CCR7 positive CCR high, 7 high are central memory and naive. That's the T effector memory that are spared. So it's the other way around. The effector memories, that's why fingolimod treatment and Novartis had claimed always in 2008 that there was sparing of T effector memory cells. There's a difference between the central memory and T effector memory cells. In fact, when you look at the populations of central memory cells and look at 17 positive cells, the IL-17, Th17 cells are found predominantly in the central memory population.
And the way I like to remember that, Asya, what Scott just said, is think about effector, you're effective, but when it's central, this is all about your self-centered problems in dealing with everybody else. I sometimes will sing the song, I'm too sexy for my shirt, and aren't I great? So when you hear about central means you're very, very egocentric, and these are the cells containing that repertoire that you'd like to differentially put away. So I think it's an important point.
Oh, okay,
So,
cool.
One other point, quick ones to make. What's interesting is that the two treatments that give you rebound and iris-like are the two that affect trafficking predominantly.
Yeah.
Fingolimod and natalizumab.
Yeah.
You could argue that they may have some effect on function, but they don't affect function the way all of the others do, which the others are their primary ways of working, or if not killing off. And so that's something that those two agents have in common. And you can think of them walled up in the lymph nodes or circulating in the blood and just dying to get into the brain and spinal cord. And when you let them, they do so with enthusiasm, and you've done nothing to kill off or make a major alteration. There are some, but a major alteration in the function of those cells. Whereas if you give them, let's say, teriflunomide, glutarama, interferons, you're affecting their function, is not so much their trafficking. So when you withdraw, it takes, if you want to argue time, I mean, it's theological almost, to get back to being able to be auto-aggressive, as they like to call it in Europe. So I think that that's something in common. The other thing is, depending with no washout, it depends what agent you use. And I don't know if Scott was on, but Scott and I have talked for a while, and he was, I don't know if he was on earlier, that we assume that the ocrelizumab and the other things get into those lymph nodes and will be killing off those B cells. But that's why I was asking what we knew about sort of a close sequence of the B cells before and how much after, before you had that attack and found that she had maybe 1 or 2, 5% B cells coming back, because the argument is, did you get to them?
Yeah.
And it's a little interesting because the rebound in this patient was at almost 6 months. The rebounds that a lot of people have seen, considering the fingolimod takes about 3 to 4 months to get you to your lymphopenia, it's a little late. So I wonder whether the ocrelizumab in a way delayed the rebound.
Yeah.
And by the way, one point to underscore there is that at any point in time, Asya and those listening, it's only about 3 to 5% of the body's mononuclear cells are actually in circulation, right? And they're trafficking. So Bob's point about the tissue, and it can be quite remote, is really important, because the vast majority of those cells are in the tissue. So what you see in the blood compartment, it's important. It's what we can access, but it doesn't tell you the whole story. 0CD19 does not necessarily militate against having CD19 cells moving around in other tissues. And then one final comment, you were focusing really mostly on fingolimod withdrawal, but goes the other way. We've seen many patients who have gone from Tysabri to fingolimod, and the vast majority of them, probably 2/3 to 3/4 that we've seen, actually will recrudesce and look just like iris, and a single day of steroids on that first month does not make it. So if we're going there for a reason, generally give 3 to 5 days of steroids for 3 months in a row, and that will quench it. By the way, there's been a number of published papers, including Rip Kinkles and others, on this phenomenology and that polarity, going from Tysabri down to fingolimod. May happen with others too. So anyway, Asya, we'll keep going.
Study.
Just in the interest of time, I know someone else is going to be itching to go very soon. So just very quickly.
That's what I was going to say. Thanks.
Just to switch gears and talk about treatment, acute treatment management. We know that steroids are first line, but they frequently don't work. adsorption is felt to be a little bit better than plasmapheresis. Luckily, we didn't have to go there. What I really want to focus on is the prevention of fingolimod rebound. So you mentioned one prevention strategy, which is to treat with pulse dose steroids several times in a row. We did not do that. We looked for another DMT to switch over to. And the key here seems to be to start a new DMT very quickly. We started it, the following day. But let's talk about some of these in whatever time we have left. So since we started the patient on an anti-CD20, I thought to look at a report of fingolimod to rituximab rebound. And this was a 40-year-old man with severe disease who was doing well, and natalizumab switched to fingolimod due to JC virus positivity, and 6 weeks later had a worsening clinical and radiographic activity. So he was switched to rituximab, had normal blood counts at the time of the switch, but 19 days later had a very bad relapse with his EDSS climbing up to 550 contrast-enhancing lesions. And
Wow.
Even with treatment, he was really only able to return to about half of his previous working activity. Here's a paper on switching to alemtuzumab. And this was a very nice study done across 6 European centers. They identified 174 patients on alemtuzumab. 36 of them were previously treated with fingolimod, and 25% of those had a significant unexpected relapse following that first alemtuzumab cycle. You can see the treatments that each of them had. Most of them were on natalizumab prior to fingolimod, and some of them also had some interferon beta before that. So wanted to have a discussion about alemtuzumab and whether maybe it potentiates a fingolimod related rebound effect. I don't know if we have the time for that, though. Just briefly, alemtuzumab may be depleting circulating T regulatory cells, but unable to target the sequestered T cells, as some of you were already pointing out. And fingolimod discontinuation is associated with an abrupt imbalance between the pro and anti-inflammatory components that we were discussing earlier. So some people have a question of perhaps, is there a role for a slow taper off of fingolimod to avoid this sort of rebound? And I'm very curious to hear what you guys have to say about that, if you have any thoughts.
Well, Asya, that's a great entree, and I appreciate you're willing to share the discussion. So maybe I could start with, let's say, Ethan Meltzer, our fellow here, who's thought a lot about these particular questions. And as you pointed out, we may not have a definitive answer, and there's some evolving evidence. But Ethan, what do you think about that issue? Would that be helpful in terms of the slower taper versus just automatically stopping the S1P sequester mechanism for the drug action? Mm-hmm. Okay, so Ethan's not around. Andy Goodman is on. What do you think? Yeah, he is on. Mike Levy.
Right,
let's go to Mike.
Mute.
Oh, there you are, Andy.
I'm here. I had so I'm not sure that tapering, there is such a thing as tapering per se with this drug. I mean, it takes weeks, perhaps months, for it to for its pharmacodynamic effect to taper itself, so to speak. So I'm not sure there's a way of doing that.
Well, certainly you could imagine having the patient on every other day fingolimod for some period of time, and then maybe twice a week fingolimod and once a week fingolimod for some period of time.
No, so I understand the notion of what tapering schedule might be. I'm not sure that makes pharmacodynamic sense with respect to its effect on the immune system.
I think that's a really great point. But it also, the stakes are high. That's why you're focused on it, Asya. So
yeah,
the aspect of your presentation is not like, nobody's paying attention that the emperor has no clothes, but we are seeing this. It's a very important observation, particularly from the standpoint of, is there a way to mitigate? Some people have no problem, but even if you have one or two really severe rebound patients, you've lost some tissue and time issues. So
I kind of shame you as a neurologist to see this happen.
Exactly. Okay, continue.
And in the last two slides, some other agents. So cladribine, not yet available in this country, but certainly available in others, was studied in a progressive patient in the INFORM study, and 6 months after, 6 months after discontinuing fingolimod, as part of the INFORM study, this particular patient with progressive MS had a significant exacerbation, unable to ambulate due to hemiparesis, and a new thoracic sensory level was also present on their exam. So just because of availability of medications in the UK, this patient's team decided to treat them with cladribine subcutaneously for 6 weeks, and a 3-month follow-up exam showed some EDSS improvement from a score of 8 to 7 and stability of the MRI. So I thought it was a potentially interesting option in terms of treating the acute relapse as well as longer-term disease if cladribine comes on the market in this country. This article over here in the right upper corner focused on 3 patients with a post-fingolimod rebound disease in great detail. And one particular patient was a 34-year-old woman with good disease control on fingolimod, EDSS of 5, but complications of lymphopenia and UTIs made her neurologist decide to discontinue the fingolimod. And 2 months later, she had a horrible rebound that was resistant to IV steroids, plasmapheresis, as well as cyclophosphamide, and she made no improvements. Long term, she remained at an EDSS of 9, so it seems like cyclophosphamide may not be the answer. And I think tocilizumab is an interesting agent to think about, because many of the papers talking about fingolimod discontinuation sort of pontificate about, well, maybe tocilizumab, an anti-IL-6 agent that we use a lot in other neuroinflammatory diseases such as NMO, may be helpful as a very strong gun. There are no reports of MS patients being treated with tocilizumab to my knowledge, but I found this one that showed a rheumatoid arthritis patient being treated with it and developing what looks like multiple sclerosis. So that's a sobering thought that perhaps that is not the answer.
And just the TNF inhibitors. We see multiple sclerosis-like lesions, and the TNF inhibitors in a clinical trial in MS made things worse. So not all autoimmune diseases are the same. In fact, heresy, we don't know that MS is truly autoimmune in using Witesky's postulates.
Yeah, one other thing, Asya, really great discussion points you bring up. Our group with collaborators published a paper in JNS 2017, volume 372, title of which is High Dose Methotrexate with Leucovorin Rescue.
I read that paper and I used it, and it was very, very helpful for me on the inpatient side. I used it the month it came out, so thank you.
What? They're very lucky to have you. Amazing. But this is something that there's not a lot out there. You can read about Cytoxan and mitoxantrone, and it's great to have these in an armamentarium. But you yourself use the term gun or big gun, which means I think you very nicely understand the dichotomy between have you quenched the ictus, the acute event, before you necessarily go on and make a longer term decision about disease modification. And as Paul O'Connor in Canada very nicely demonstrated with natalizumab, that once somebody's hot in the head or they've got a hot bowel, they've got Crohn's, we can use natalizumab for both. Natalizumab really doesn't have the kind of impact on the various factors we'd like to see fall to exact remission. And it's the direct opposite with the methotrexate, where you really are getting the upper hand, killing cells, and then have some time to make the transition to say, okay, what are we going to do for this patient in terms of their disease modification going forward? So
natalizumab takes about 3 months if you look at the stuff by Rick Rudick to work, which is why when it was first tried as instead of corticosteroids for relapses, corticosteroids were better because they work right away.
Bingo. Okay, Asya, keep going. Sorry for. And by the way, Doris, I'm going to send you this paper. Maybe we can distribute it
thank you.
Among the group. That would be very obviously. Asya is ahead of all of us, but no, but it's very important.
I used it. It came out at the perfect time.
You worked for it, and it's an amazing thing when you get the upper hand. You've done something important. And I'll just point out the last paragraph of that paper. I was very surprised, Bob, that the editors let me put this in there. And I talk about, fortunately, I was able to convince the family to give me another shot. There's a bit of a editorialization there, but I think it's, if you read Asya, I would be hard pressed to think that you wouldn't say, oh, Froman and I are cut from the same cloth, how dangerous that could be. But it does get to this issue of you never quit, you always try. And that's really how we got onto the high dose MTX with leucovorin rescue years ago. Okay, so let's go ahead and summarize, and we'll
in summary, obviously fingolimod is a very attractive disease-modifying treatment. It's the highest efficacy oral agent, but discontinuation is very tricky, and it may be a time of increased risk, and patients need to be counseled about it. This increased risk may be due to an imbalance of inflammatory and regulatory lymphocytes, and it's important to have a smart exit strategy, at least a couple of things that you may be willing to try in case something like what happened to our patient happens to yours, but we don't have that best strategy clearly laid out for us at this time.
One last comment. That was terrific, but there's one thing to remember. You're probably right. The position that we took in the AAN guidelines is that fingolimod is probably the strongest, but you don't know that unless you've seen the study that's head-to-head against the other pills. You don't know that. You don't know it.
Thank you for bringing that up. I completely agree. We all look across trials, but be careful. We still take care of patients one at a time. That N is one. That's an art form. He's quite right. The degree of heterogeneity is enormous. So get careful comparing across studies. I think that's right. So I'm going to take chair or director prerogative and let Peter Squigna from UT Southwestern and his mentor Ben Greenberg for the case that he's going to present to the group. So Peter.
All right, Peter. Yep, there you go. All right.
Thank you, Asya. Great.
Yeah, fantastic presentation. That's actually going to segue in very nicely with our presentation today. And it's not a very complex case, but I think there's a lot of intricacies in terms of management and labels. So with that, we'll just get right into it. If it will, there we go. So our patient here was a 59-year-old lady. She presented to an outside hospital with a chief complaint of water on the leg. She went to bed intact, and when she awoke, she had this sensation specifically in her left leg. There was no motor symptoms at the onset, but that she did notice that her walking was a little bit different, but not so bad that she couldn't go to work. She goes to work, her legs becomes more numb over a time span of hours. Again, she's not walking right. She starts to get some comments from her colleagues, and she heads to an emergency room. By the time she gets there, she can't move either leg. The way she describes it, it's not a flicker of movement, and she can't feel anything below the stomach. She does kind of give this dermatomal description of sensory loss. And she didn't even realize it, but when they evaluated in the emergency room, she had incontinence of both bowel and bladder. So all of your symptoms there. So she has an interesting medical history. So she's got fairly advanced rheumatoid arthritis. She was managed by an outside rheumatologist. She was actually taking flutamide for a number of years, but they felt that she had poor control of the disease. She eventually was treated with two different TNF-alpha inhibitors, etanercept and adalimumab. But eventually discontinued both to adverse effects of the infusions. And interestingly enough, and I've actually quoted the same paper, she got a dose of tocilizumab about a month prior to her presentation. Because of all the switching between the DMARD, she's basically been on or off prednisone 10 milligrams for the last year or so. And just for completeness sake, I just included her surgical history, which may or may not be relevant at the end of the day. She was having this chronic back pain. She saw a surgeon out in the community who performed a posterior thoracic fusion. Unfortunately, she didn't notice any improvement in her symptomatology, and so she actually went back thinking maybe they got the wrong segments, and again, there was no improvement in her symptoms. She's a sister with rheumatoid arthritis. She doesn't smoke, doesn't drink, works as an accountant. She's a pretty straight person. And her exam, basically, apart from some mild hypertension and obesity, nothing remarkable on her vitals when she saw us in the clinic. Basically, everything above the neck is intact. Getting into the meat of it, so she had decreased bulk in both her lower extremities as well as increased tone. She's about 4 to 5 in the bilateral lower extremities. So quite a remarkable improvement from where she was in the emergency room. She's got some asymmetry in reflexes that switches at the heels, and she's got the sensory-loss to go with it, with the localization. She's using an AFO in her left leg, and she's using a rollator, but she's able to get around a little bit. So basically, we saw her, and without getting too far into the imaging, we sent a Mayo CDS1 panel, which she doesn't have an antibody associated with the condition, and we were able to obtain her laboratory studies from her hospitalization, which spinal fluid has slightly elevated protein, but that's about it. They actually had not sent oligoclonal bands or anything else that could have been useful. So even before I went to the imaging, I knew I really had one job on the imaging, is that was to find a brain lesion. I figured she was a 59-year-old woman with obesity and hypertension. I thought this would be easy, but at the end of the day, I just couldn't find anything in her brain. Totally clean. And these are images from the outside, and I apologize for the quality here. But basically, there wasn't a whole lot, and I think this caused a lot of confusion. There's some, sentiment that she was faking a lot of her symptoms, unfortunately. And so I think that may have sent them down the wrong path. You get about one slice on the cervical spine, but I think if I can convince a couple of you that if you squint your eyes here at the upper cervical, or excuse me, lower cervical spine, you might see some T2 signal in the central cord there. When you go to the axils, you really can't appreciate it very easily, but if I can invert it, I think I can convince at least some of you here on the call that there's a little bit of increased signal on the left predominantly compared to the right, which would kind of bolster the argument here. We did obtain the outside radiology reading. Again, they had interpreted unremarkable. When we repeated the imaging, when she came to our center, it wasn't terribly impressive on our imaging, but the radiologist did agree that they did find some T2 signal actually in her thoracic cord as well, both on the ventral and dorsal aspect. So while she was in the hospital, she actually got 8 days of IV Solu-Medrol, and as well as concomitant IVIG. She had an incomplete recovery. And they actually transitioned her to plasma exchange, and she actually made a fairly significant recovery. And so when she came to us, she really wanted us to give her a diagnosis. They told her imaging was normal, so she was curious what she had. And I'll reference this very nice review here. Someone had referenced the transverse myelitis purely on a history basis, a history and exam basis, which I think is accurate. But that's where that's going to fall, I think, is the very interesting thing. Whether she would fit criteria for NMOSD, I think we were a little bit uneasy. Just going through our criteria. She really didn't have the LATM. There wasn't any gadolinium enhancement. She had negative antibodies, so we were a little hesitant to say she fit criteria for this disorder. And we're the national, this is the multiple sclerosis conference call, whether she would fit criteria for multiple sclerosis, even with the 2017 conditions. She lacked dissemination in space. Even if she had oligoclonal bands to fulfill criteria for dissemination in time. But at the end of the day, we felt that she did really fit criteria for the clinically isolated syndrome. This is a characteristic localization, even though there was near complete myelopathy. We felt that we have to give her a diagnosis at the end of the day. And I think this is particularly interesting because where the line is drawn between the clinically isolated syndrome and multiple sclerosis in itself is particularly interested in where you would push to treat rather than not treat. I think is an interesting conversation to have with the patient, especially our patient. She's got a lot of these risk factors. She actually had low vitamin D, she's got obesity, she's female, she's got spinal cord lesions. And so her risk of conversion to clinically definite multiple sclerosis is an interesting one. And as referenced by Dr. Lissack, she has this interesting history with the rheumatoid arthritis, and specifically her exposure to TNF neutralization agents. And again, this is the trial, I think it came out in 2011, which shows a very nice, well, unfortunately, the greater the exposure to these TNF allergens, the higher risk of relapse in multiple sclerosis patients. And this was not willy-nilly. There's high expression of TNF alpha and demyelinating plaques. It seems to be a risk factor for relapse, and it was actually efficacious in the EAE model. But when it came to humans, it just didn't pan out. And so not only is it's been shown to not be efficacious.
By the way, just as a quick aside, there's been some work in EAE, it was published in Brain a few years ago, manipulating the TNF alpha receptors. And there were two of them. They were able to do some things in an EAE model. So it may have to do with the difference in the receptors, not which is why in MS it may be bad and rheumatoid it may be okay, partly because it's very complex receptor interactions. But there's no question, and as I mentioned before, I've seen psoriatic arthritis and rheumatoid arthritis patients who've never had anything that resembled MS come in looking like MS or ADEM.
Right. Exactly. And very similar to our patient here, there's actually been a suggestion that there's a distinct myelopathy associated with TNF alpha inhibitors from a case series from Dr. Pardo here, which actually very similar stories to our patient. And very eloquently summarized previously, there's actually been this paper, and this was news to me. I didn't know if anybody else had any kind of similar experience with multiple sclerosis developing after exposure to tocilizumab, which seems quite counterintuitive to me. I'm not sure if it's going to have played a role here. So we actually diagnosed her with a TNF alpha inhibitor associated myelopathy. And the question I think that's been in the literature, and I think it's only going to get more complicated as we get more tools in the toolbox and our colleagues are using other agents to manipulate the immune system, is what is her risk of developing multiple sclerosis? Looking at the population-based studies, the risk of the TNF alpha inhibitor seems to be around 0.8 per 10,000. That's coming out of Spain, actually. The range is quite profound. And so at the end of the day, we reached out to her rheumatologist, and we had a discussion of leflunomide versus teriflunomide. Now, she had been treated with leflunomide for rheumatoid years prior, but this is a very nice intersection of treating a patient with multiple sclerosis with a comorbid autoimmune disorder such as rheumatoid arthritis, where you can get double efficacy. Well, I can't say that for definitely, but at least we think, given the similarity to teriflunomide, that it was just an attractive option for her. And yeah.
One other point about
I'm sorry, go ahead.
something about myelinating cells, because one of the other side effects that we've seen with TNF receptor TNF inhibitors or TNF receptor inhibitors and things like that is we've seen CIDP-like illness, and it's been well reported. So it's interesting. It's not just CNS inflammatory diseases one sees in rheumatoid and psoriatic patients who get these agents, but it's also affected peripheral nervous system myelin too.
Hey, Peter, it's Elliot again. Let me ask you a question. Very interesting. You really focused on this issue of TNF-associated demyelinating disease. You know, when you talk to your MS patients and they have a family of kids or siblings, people want to know what's my risk for seeing MS in other members of the family, and people are preoccupied. But as you probably know, it's compared to the general population, let's say 1 in 1,000, these patients likely have a 2 to 4% in the family. You've got one, you have another. But what's really interesting and conspicuous is that the other family members actually have probably a 12 to 13-fold increase of having a different autoimmune disease, right? So one thing that's interesting, if you look at the Lemtrada story, that, you know, you're a great responder, you exact remission, but now this patient, of course, is at a predisposition for secondary autoimmunity. We could talk about that some other time. So the question is, when you have this robust response and exacted remission in MS, have you converted that MS patient to their non-identical, let's say, sibling, where there is this risk for other diseases? And you're sort of seeing this in the opposite way in terms of TNF unmasking demyelinating disease. The other issue may be when you suppress demyelinating disease, you may be carrying a genetic cassette for these autoimmune diseases, and you may have changed the predilection and the profile by treating and exacting remission in one of them, but it still opens you up to get a different autoimmune disease.
Right.
So, Peter, is that your last slide?
That was with alemtuzumab, the interferons. There's some stuff about thyroid and the myelinating neuropathies. Mother Nature doesn't like being fooled around with to some degree. So it's an interesting problem. In the old days with penicillamine, you can get myasthenia. And most patients, when they stop the penicillamine, remember that you have increased incidence of RA with myasthenics anyway, most of them stopped having their myasthenia, but there have been a few in the old reports from Dawkins in Australia that, quote, stayed myasthenic, and this is in the old days before we could measure antibodies particularly well. And the question is, did you just bring it out because 4% of myasthenics have RA or lupus, eventually have RA or lupus anyway? So it's really hard to be sure, but I think we may want to see long-term follow-ups of some of these checkpoint inhibitors, whether when you stop those, if you can, some of the autoimmune myopathies that they've been getting in myasthenia, whether they go away or not.
Right. Yeah. Yeah. That's an excellent point with the PD-1 and the CTLA-4. You know, we're starting to see a lot more, and it's interesting from a pathophysiology standpoint.
And let's also remember the Nobel Prize for Medicine and Physiology this year was awarded to the Berkeley and the Japanese scientists that really characterized the CTLA-4 and the PD-1 pathways in terms of you don't want to take the brake off or put the brake on when you're addressing malignancies, right? So this can be an incredibly valuable tool to understand that new biology. We have an MS patient who developed disseminated melanoma with METs a number of years ago, 5-6 years ago, who we got Keytruda for, right? So PD-1 drug in terms of targeting, and that patient had every one of those lesions melt away. The old school, 5 years ago, whatever, they'd be dead. Every single one of those METs resolved. He appears to be melanoma free. It's really remarkable. The cells had a very high cell surface expression density of PD-1. So part of this, the new age in terms of application of surgical strike immunotherapy is going to be contingent on, do you have the right goods or the right stuff, or are we going to have a way to actually induce the induction and cell surface localization of those ligands so we can go after them?
If you look at the last, because I have to get off, but if you look at the GWAS study in myasthenia in I think it was all AChR antibody positive patients. One of the genes that kept showing up is in that CTLA CD28 SNPs in there. So it's telling us something.
Yeah.
Elliot, this is Michael. Can I jump in real quick?
Please, Michael. I thought you left us.
I did. I jumped off and jumped back on. I love these calls.
Thank you so much.
Since we brought up Dr. Proto's paper, I think it's also important to bring up his other passion, which is vascular myelopathy. And if he hears about a 59-year-old woman with vascular risk factors coming in with a myelopathic syndrome, first thing on his list is vasculopathy. Has that been worked out? in this patient worked up?
So yeah, we're actually are going to get her set up for a spinal angiogram to further, investigate this. But it was kind of hard to ignore the TNF alpha and whether we don't know if she had oligoclonal bands, so she'll probably end up getting lumbar puncture at some point, depending on the results.
Michael, your point is really amazing because Bob Lissack knows the history better than anybody on this call. He was the editor-in-chief of JNS for 22 years or something. But if you think about it, the MS Society is formed in 46. Cabot identifies the oligoclonal band in 48, and then some three-letter acronym basically distracted us. We were all ADHD clinician scientists, and that three-letter acronym is EAE. So for a lot of times we spend thinking that this is a predominantly T-cell disease. People forget about the B-cell limb, and it takes many, many years for us to come full cycle all over again. So that's one issue. It's a T-cell disease, not so much. It's demyelinating, it's B-cell, it's T-cell, it's neurodegenerative. But you just brought up something very interesting, Michael, about the vascular hypothesis, because when we were in training, we were always taught that, you see somebody with a central or myelitis kind of syndrome, vascular is usually not on your list. It's not absolute, but your comment is really poignant because you have new techniques, ways of looking at these things, and it turns out it's not so straightforward. It doesn't have to be an Adamkowitz. They could have vascular malformations like Foix, Agenolin, and others. So your point is really well taken. And by the way, an inflammatory lesion, and obviously Mike Levy's on the call. He does the NMO, transverse myelitis. He does everything. Mike, you must see patients periodically that have such significant cord edema, and they have some maybe congenital canal stenosis, and now you've got a patient set up with a vascular risk for another reason, and that is they're embarrassing the corona, the vascular corona or the vasocorona around the cord, and what begins as robust inflammation in water can actually culminate in multiple level infarcts because of the deficiency in the vasocorona to keep flow going.
Pressure can do that, by the way. There's an old series of studies using, I think, monkeys dating to the 60s, looking more at cervical spondylosis type phenomena of pressure. And by blowing up balloons in a canal, you get sometimes the lesion is vascular and not exactly at the exact level where the big bulge is or the balloon is, but above or below it for the same reason.
So, Michael, last couple of points, are you doing any investigations or any ascertainment to look at patients? Particularly, you've got this captive audience of people. If they've got a problem, they want to come see Mike Levy at Hopkins. So are you guys doing anything different in terms of assessment or testing paradigms or non-invasive MR cysternography? Have we made improvements in the cord, getting over the pulsation and CSF and blood artifacts?
I would say that we've made progress on the spinal angiograms, the conventional ones, in terms of limiting the risk. So far, we've had no strokes among 300 angiograms, so that's good. And in also assessing not just for AVMs and other fistulas and things like that, but also looking for reduced flow as a measure of venous congestion and maybe even arterial stroke. So I think, as you said, there are new tools out there, and in the right hands, people can really get a better sense of the vascular perfusion within the spinal cord.
By the way, any investigation along that? I'm sorry. Go ahead. Yeah, go ahead.
It's Scott. Listen, I wanted to ask a question, but then it became a comment when you started picking on EAE. But let's let that go. From having been the first to show that a T-cell clone can mediate an autoimmune disease, you can't do it with the B-cell, but that's separate. I just wanted to ask on this case here, and this following up on what Michael had asked before, and that's what I wanted to ask, is how convinced are you on the temporal sequence here that it really is a TNF receptor antagonist? I mean, if you go back to the medical history and just look at, medical and surgical history, Enbrel a year ago, Humira 1 year ago, I'm just wondering, the temporal sequence, is this all consistent with people's experience of having used those where they have seen, a demyelinating condition such as TM here?
Yes.
Yeah,
That's a yes.
Oh, yes.
Affirmative.
Yes, I've had numerous, including patients who have MS and RA, or MS patients that have MS and psoriasis, and they took Raptiva off the market with 4 PML in first 500. People brought in their albums. They're like wedding albums, but it was their psoriatic plaque history in these pictures. It was remarkable. And in some of the patients, their rheumatoid arthritis is so severe with joint destruction, and these are not ones that have sort of incidental MS after the treatment. They already have MS, and they have RA. And then I've got to pick multiple poisons, right, one for the RA or one that covers both, but a second drug to make sure that I have adequate coverage of the patient's multiple sclerosis. I've had a number of those referrals to me, and almost always we get them in control.
Was this patient then on a TNF inhibitor for continuously? It says from 1 year ago, Humira 1 year ago. I guess I was just looking back at that slide again, and I was trying to figure out what the duration, or they were on consistently.
She had gotten about 2 or 3 doses of each of those. And they're monthly, so she got 4 or 5 months.
Okay.
I see.
Okay. So it does fit temporally then. Okay.
Not quite the exact. Yeah, it's good. Any other questions? I don't see. Hold on one second. Do we have questions that have been written? Yes, it is. We're just we're talking. Yeah. Okay. So Bob is signing off, and I already sent Doris the PDF of the methotrexate followed by leucovorin rescue paper. So we'll distribute that. Before we go, though, any other comments or questions? We have a few minutes in case you have
one last comment. Elliot Scott here again. Just the point came up about leflunomide and teriflunomide. Just to point out that the active ingredient of leflunomide is teriflunomide, and it created a lot of problems when Genzyme and Sanofi got the patent. They had to fight for that patent because leflunomide had already been approved for RA, and it was known that teriflunomide was the active ingredient.
That's a great point. Andrew, did you have that's a great point, Scott. Andrew, did you have a comment?
Well, my first comment, I'm glad Scott brought that up. Exactly correct. But I actually have a question for the group, and that is sort of almost philosophical question. When we see these post anti-TNF demyelinating syndromes, when is it MS? Is it ever MS? How do people approach it?
It's a great question. What we do know is that you look at the scan, it is your patient's scan. You still have to, I think, address and respect that you've got another inflammatory ictus. It just happens to not be in the joint or somewhere else. It is in the brain. So I would treat essentially all of those patients. The bigger question is, are you going to put that patient on disease modification, or
that's the corollary to my question.
Yeah, if they need a TNF agent and did not have sufficient control of the other disorder, then I've made the argument and have done it to use a TNF drug, but in conjunction with an agent that has also the ability to control or at least mitigate the risk of inflammatory demyelination. By the way, whether lesions that are clinically not relevant in terms of being occult, or whether it's an eloquent pathway. But with the first one, Andrew, the tough thing is if they've been stable, they have one. The question is, do you treat that, put it down, maximize recovery, steroids, Plex, chemo if you have to? The question, and that is your question, where do you go later? But if you already know this patient requires TNF therapy for their other disorder, and you've already demonstrated an ability to bring this patient to threshold for a central nervous system syndrome, then I would vote to make sure you either have a therapy that covers both, or you have the patient on 2 therapies. They've already shown you the goods, and do you really want to take the risk of allowing them just to fly, knowing full well it's not covering the CNS compartment, and events are substantially more disabling, more destructive when people are not on disease modification agents for MS, for example, than those who are.
Okay, I'm not sure you're
That's a
answering
great.
my
That's a
question. But okay.
No, come again. It's philosophical. The question you asked is, when is it MS, or when is it something else that it's a similar pathology, but the other factor?
So my point is there a monophasic or perhaps even multiphasic anti-TNF induced inflammatory demyelinating condition that is not equal to MS? Or is it in fact MS that is, whatever you want to say, whatever the mechanism may be, unmasked or released or identified? That's sort of the.
But you see the problem, if they have a classic demyelinating syndrome, they've got bands, high index, they have these features. So you really are stuck in terms of, it really is indistinguishable in many levels. But you're asking about the course, and you can't predict it going forward. So the question is, do you let them ride? And maybe they never have another event. You may be right. Maybe the whole thing's monophasic. But that's a great question to actually study. And people have combinations of immune-mediated disorders. In fact, I think it's the hardest question, and it's a very important question. Maybe the best question of the night from that standpoint. Because the real answer is, we don't know. All right. Kathy, Doris, any final comments for this evening?
We've got a comment from Stephen on the chat. He wants to know, would you favor choosing B-cell therapies in situations when there are competing systemic and CNS autoimmunity processes?
Peter, you're up. What do you think?
I think that's a great idea. I think it would depend on the comorbid autoimmune disease. There's really good efficacy for B-cell depleting therapies in rheumatoid arthritis, and it's something we've thought about. I think if she fails leflunomide, I think she'll end up going down that path.
By the way, that's a beautiful, parsimonious answer, Peter. That's why we love you, and I wish I could do the same. So, any other comments or questions? So if there are not, then what we could do is end a little bit early this evening. I don't know how that started. We go to 6:15, but I want to thank the two presentations, Asya, Peter. These were gorgeous. Lots of great discussion, and I learned a number of things, including provoked by Andrew Goodman's question that, boy, we have more to learn. This is not all worked out, and it's really encouraging to see the group that's assembling every month and contributing to these. And somebody mentioned earlier about increasing number of people going into MS and neuroimmunology. We're seeing very much the same thing, and I'd say probably the factor that's driving that more than anything else, other than being around these incredibly bright and exuberant people, is really the advent of neurotherapeutic options for our patients. It's been the major game changer, and it's taken people from feeling like they're vulnerable, a ticking bomb. I have MS and MS has me, to the point now where patients really feel more confident that we can achieve the upper hand. We have to decide which one is really the drug for an individual patient that will do that, and they have quality of life, so it's very important. But this conversation is so different from the ones that we had even just 10 years ago, 10 years ago. Dramatic. So Kathy, Doris, thanks again for putting this all together for us to get together and have these discussions. And I look forward to our next session, the second Tuesday of the month, coming up in March. And please make sure you guys are looking at Neurology N2. We've got 2 already that have come out, and a 3rd that is accepted, and 2 more that we're reading. And potentially we may have some discussions about invitations for other contributions and submissions to our little section in the journal, which is from the National Multiple Sclerosis Society case conference proceedings. So I think with that, we'll go ahead and stop. And thanks so much for all of you who got on the webinar and contributed. It was fabulous.
Thank you so much. Good night, everyone.
Good night.
Good night.
Bye-bye.